that will be watching. I hope I got that enabled. We will see. All right, let's get started. There's my information. We've got the objectives for those of you who are needing your CEs. But let's get started with vascular dementia. It's exactly what it sounds like. Anything that affects the cardiovascular system is affecting the brain. If it's bad for the heart, it's bad for the brain. The most common cause of vascular dementia are those little tiny strokes that many people have that are called TIAs. TIAs, and people will have multiple minor strokes or other conditions that affect the smaller blood vessels. And that is called multi-infarct dementia whenever somebody gets diagnosed with this. This is also the only dementia that can come on suddenly because it can come on after a stroke. Now, sometimes a person will say something like, oh, my loved one was perfectly fine until they went in and they had a surgery, they had anesthesia, and they came out with dementia. But then as we start talking and going through those 35 or 36 common symptoms to dementia, they realize, yeah, actually, they were doing a lot of those things. We just didn't realize it was dementia. Excuse me. General anesthesia, though, being the #1 accelerator of all dementias. We want to stay away from general anesthesia if we can, all of us. It accelerates dementia. So vascular dementia is the only one that can come on suddenly. Sorry, you would know that would start right when I start talking. I'm going to get a tickle. And the reason vascular dementia happens is because it's very simple, an inadequate blood flow to the brain. There's all kinds of reasons we get an inadequate blood flow to the brain that has to do with the vascular system. Diabetes, smokers, somebody with high cholesterol, high blood pressure, obesity, depression. Now, when I say all of those, if you were sitting there and your eyes started getting wide because I just listed everything that you've got, untreated. If your diabetes is under control, if your blood pressure is being treated, if your depression is being treated, if your cholesterol is being treated, then this is not you. Whenever we are treating them, then we're not having the issues with the narrowing of the blood vessels. It's whenever these are not treated. And when we get to the section on depression, we're going to see whenever we treat depression, how that is helping as well. So what's going on with vascular dementia? Many times vascular dementia will coexist with another dementia. In fact, Jamie and I were looking at some new statistics that came out in August that said that a dual diagnosis or a mixed diagnosis has moved up to either #2 or #3 behind Alzheimer's now. So vascular dementia, you can have Alzheimer's and vascular dementia. You can have Lewy body and vascular dementia. You can have frontotemporal and vascular. You can have Parkinson's and vascular. And many times a person will have 2 different types of dementias because they will have Alzheimer's disease, which is the most common type of dementia, plus they'll have cardiovascular issues, so they'll develop vascular dementia. If you ever look at your loved one or a resident or a client's chart, whichever one is listed first is the one that they were diagnosed with first. And often this is going to coexist with depression. So again, these are going to tie together. So what do the symptoms look like with vascular dementia? With all of the dementias, it is so individualized. And the reason it's individualized is because it's going to depend on where the stroke took place or where the damage is done in the brain. So one person with vascular dementia can look completely different from another person with vascular dementia because the damage in the brain is in a different place. So if you look at the third bullet point there, The cognitive symptoms tend to develop gradually when the underlying cause is a chronic blood vessel problem, such as diabetes or high blood pressure. Then it doesn't tend to come on suddenly, like just with a stroke. These conditions slowly narrow the blood vessels, progressively depriving brain tissue of oxygen. This can result in subtle changes over time, where it doesn't just all of a sudden happen. So you see there some of the things that we may start seeing. We may just start to see some subtle personality changes where we're not really picking up on what exactly is going on here. And if we don't know a lot about dementia and all we know about it is memory loss, and we don't realize that there's about 35 other symptoms to dementia, we may not even understand what's happening. They may just start having issues with their speech. That's called aphasia, because that's the part of the brain that's being affected, and they're not even having any memory loss yet. And it's because of the blood flow that's not getting to that part of the brain. Or if it's affecting the temporal lobes, which is right here by the temples, they may be having difficulty with their memory. This one gives a better idea. And again, you're going to get copies of all of these. You'll be able to run them off and see them a little bit better. This is the second most common type of dementia behind Alzheimer's disease. So that number one question that we get asked, what's the difference in Alzheimer's disease and dementia? Alzheimer's disease is the number one type or form or kind of dementia. Alzheimer's is dementia. It's the most common type of dementia. But a person can have, there's 130 different types of dementia, but about 70% of them are Alzheimer's. But you can have Alzheimer's and vascular, like I said earlier. But the second most common type is vascular. 20 to 30% is vascular. And again, depending on where the damage is in the brain, then you'll get these type of symptoms that you can see here. So, for example, if the damage is in the frontal lobe of the brain, then they may have a hard time making good choices because that's where judgment is. This is also where our filter is. Don't say that. Don't do that. And if that's where the damage is, they may not necessarily be having very many memory issues yet, but they're having some judgment issues. Memory's coming later. This is the one dementia that we got some control over because we can do things like control smoking, alcohol consumption, our weight, receiving general anesthesia. If we can avoid it again at all costs, we want to always talk to the doctor to see if there's another option. Can we have a spinal block instead? Can we have a local? Can we not be put under until the very last minute, until we have to be put under and then brought up immediately? Making sure we're taking our prescription medication like we're supposed to take our prescription medication. Exercising, making sure we're eating like we should. So again, vascular dementia is the one dementia that we do have a little bit of control over to protect our brain. Like I said earlier, with the symptoms with vascular dementia, it's going to depend on where the blood vessel damage is in the brain. So memory loss may or may not be a significant early symptom. What it may show up is confusion, disorientation, trouble with the language, that aphasia, physical symptoms such as trouble walking, headaches, numbness, even paralysis. They may have trouble with their judgment. You might even get something where they have uncontrollable laughing and then uncontrollable crying. There's commercials about this because there's a medication that can help with that, where they'll laugh and then they'll cry. Impaired function in social situations where they'll do things that are inappropriate, like they lose their social skills. And then their symptoms will remain stable for a period of time until they have their next cardiovascular incident. So this progresses in more of a step pattern, and we're going to watch a little 3-minute video that's going to describe that in just a minute. One of the ways that we get diagnosed and that we can see vascular dementia is with neurocognitive testing, which measures brain function. And most of the time, it kind of gives us a snapshot of where they are in this moment. They will look at attention, they will look at processing, they will look at memory loss, focus, speed, and then using an MRI as well. Here are some MRI photos that shows us some vascular brains. The arrows that are on these, if you'll look and see especially, it shows a little bitty, that's called a pinpoint stroke. A little tiny pinpoint stroke, that would be a TIA. That shows you the lack of blood supply to the brain. Now in A, you can really see the difference there. There's a lack of blood supply to the brain. You can see where it's, so in that person's brain, whatever area of the brain is being affected, that would determine what kind of behaviors that person was having. Same thing with B and D. That's why I tried to choose some that had different areas being affected, because their behaviors are going to be different. Life expectancy of somebody with vascular dementia. Because this is the cardiovascular system, if it's developed before the age of 65, many times the life expectancy of these folks is only about 3 years. If it's developed after the age of 65, the average life expectancy is about 5. So that being said, average 5 means that some folks are living 10. It's very, very common for them to die from a stroke or a heart attack because they're having cardiovascular issues. Life expectancy is lower than other dementias because they have underlying vascular issues. There are no medications to treat vascular dementia, just like there are no medications to treat any of the dementias. The only medications are to treat the symptoms of the dementias. The best thing for vascular dementia is to control the risk factors. And those are things that we can. And again, that was controlling things like diabetes, high cholesterol, smoking, alcohol, diet, exercise, those type things, risk factors. And that last bullet point there, according to the Alzheimer's Association, there's substantial evidence that treatment of risk factors may improve outcomes and help postpone or prevent further decline with vascular dementia. So here is that short video I was telling you about. Let me see if I can get it to load real quick. And this is going to summarize and kind of give us vascular dementia in a nutshell.
What is vascular dementia? Vascular dementia is the second most common type of dementia. It is caused by problems with the blood supply to the brain. Nerve cells require oxygen and nutrients to survive. Without them, they will become damaged or die. Cells are provided with oxygen and nutrients by a network of blood vessels in the brain. When the blood supply to the brain is interrupted, for example, by a sudden blockage or a leak, this is called a stroke. A stroke can cause significant damage to parts of the brain. When the parts of the brain responsible for memory, thinking, or language are damaged in this way, a person will have difficulty remembering things, thinking, or speaking. These are all symptoms of vascular dementia. Sometimes, a single large stroke is enough to cause the symptoms of dementia. This is known as post-stroke dementia. This scan shows damage to the brain of someone with post-stroke dementia. In other cases, a person may experience a series of smaller strokes that gradually cause damage. This is known as multi-infarct dementia. Following a stroke, a person's symptoms may remain constant for a while. Then, if the person has another stroke, they may notice a sudden worsening of symptoms. This is known as a step-like progression. Small vessel disease is where there is a narrowing of the blood vessels deep in the brain. Small vessel disease is the most common cause of vascular dementia. As the narrowing affects more small blood vessels and more of the brain becomes damaged, the person will experience a gradual loss of abilities. Usually, people with small vessel disease notice a slowing of thinking and problem solving. For example, taking longer to think of a word and write it down. Evidence suggests that lifestyle factors that promote a healthy blood supply, such as regular exercise, not smoking, and eating a healthy diet, could help to reduce the risk of vascular dementia. There is currently no cure for vascular dementia. However, by controlling underlying cardiovascular diseases which affect the blood supply, such as high blood pressure, high cholesterol, and heart disease, it may be possible to slow down the progression of the condition. Vascular dementia will affect people differently, depending on the parts of the brain that are affected. However, a common symptom is having problems with planning and organizing, or with concentrating. It can help to break complex tasks down into smaller steps and to make sure that environments are not too busy or noisy.
Some other treatments for vascular dementia, and this is actually with all dementias. So throughout the course of all dementias, physical therapy, occupational therapy, and speech therapy. Even after a person has gone on hospice, physical therapy, occupational therapy, and speech therapy can still be used for comfort measures because they tap into muscle memory. They are not teaching them anything new. They're tapping into muscle memory that has been there for a very, very long time. So I went into detail with these. I'm not going to go through them. You'll be able to read them, but these are great therapies that a person who has any type of dementia, not just vascular, can go through that will help them. Also music therapy. And there are people who are music therapists. We have one on staff here at the West Center. So music therapy also is a fantastic thing for a person with dementia. The right side of the brain tends to deteriorate much slower than the left side of the brain. And the right side of the brain is where music is stored. It is the rhythmic side of the brain. And so a person who may not have even necessarily been interested in music before, lots of times that's how you can communicate, is through music. Other interventions that we use for vascular dementia is education. What you're doing right now is learning as much as you can about the disease so that you can better communicate with your loved one or with your clients or with your residents. Changing the environment, like the video said, avoiding noise, glare, and clutter, and then monitoring their personal comfort. Not being confrontational, remembering those things that we say all the time. If you're familiar with our programs, you hear us, Jamie and I say, a person with dementia is never giving you a hard time. A person with dementia is having a hard time. We can't make them come to our world. We have to go to their world. Making sure that they have adequate rest, and then using 4 things for redirection. Food, the sweeter the better. Music, their music, animals, and children. And if you don't have real animals or real children, YouTube is wonderful for that. Go to YouTube and find some funny animals, especially like puppies, kittens, and then laughing babies, children, videos of children. And then how can you help somebody who does have dementia? Focus on quality of life, being flexible, entering their world, practicing self-care and compassion. And then I've also put a couple of pages of resources on here for you. And then let's go right into stroke, because stroke and vascular do tend to go hand in hand, since most of the time we will see that those strokes, those TIAs, is the cause of the vascular. So stroke is what takes place when the supply of blood carrying oxygen to the brain is suddenly cut off. So again, we talked a lot about stroke when we're talking about vascular dementia. You'll hear whenever you're reading about stroke, you'll see this over and over, the FAST, the face, arm, speech, and time. The face may look uneven. If you look at somebody, one arm may be hanging lower than the other. Does the speech slur? Because typically right after a stroke, the speech will slur, and then you need to call 911 right away. Because if they can be given a medication right away, especially if it is a clot, and we're going to look at a couple of different types of stroke, you can avoid some severe consequences if they can be given that medication right away. It depends on what part of the symptoms of stroke depends on what part of the brain is affected and the extent of the damage again. So diagnosis, again, they're going to have an MRI. Many times they'll go ahead and do a CT scan. They'll do an ultrasound to check the blood flow in the carotid arteries up in the neck, and then prevention of a stroke. Same thing as with vascular dementia. They go hand in hand. Diet, exercise, controlling diabetes, cholesterol, blood pressure, avoiding illicit drugs, smoking, and alcohol. But then with treatment, so treatment for stroke, they can use clot dissolvers, and that dissolves clots and opens arteries. Anticoagulants that have the effect of inhibiting the coagulation of the blood. Then there are several different procedures that can be used with stroke. There's catheters that can be used, angioplasty and stents. If a person has an aneurysm, they can be clipped. There's several different procedures that sometimes have to be used. Therapy after a stroke, rehabilitation. There are specific therapies. Sometimes after a very major stroke, a person may go to a rehab center, and it's advised that that starts as soon as possible. And again, that's the physical therapy, occupational therapy, speech therapy. And most of the time when someone goes into a rehab center, they'll also use that music therapy. A lot of speech therapists also have a lot of training in music therapy. And again, it says it's going to focus there on speech, cognitive therapy, sensory and motor skills, and physical therapy. And then nutrition after a stroke, really strict diet being overseen by a dietitian, nutritionist, and recommended, again, fruits and vegetables, whole grain breads, lean proteins, low fat meats, and limiting salt intakes. So here's some pictures of some strokes. You can see here again, tried to find 4 very different scans so that you can see we would not expect the person in picture A to have the same behaviors as the person in picture C. The damage is in 2 different places. Same thing with B and D. So just because you've seen one person with a stroke, that means you've seen one person with stroke, or one person with a vascular dementia. You've seen one person with vascular dementia. That's the same with each of the dementias. All right, let's watch this short video on stroke. It will load, there it goes. And then we will get to depression.
A stroke is when the blood supply to part of your brain is cut off. This can cause your brain cells to become damaged or die. A stroke can happen to anyone, and there are 2 main types. The most common is an ischemic stroke, which happens when a blood vessel in the brain becomes narrowed, and a blood clot forms, causing a blockage. Sometimes this blockage is only temporary. This is a transient ischemic attack, or TIA, and is often called a mini-stroke. A TIA may feel like a funny term, as you may experience slurred speech or confusion for a short time, and then get back to feeling well again. The other main type of stroke is a hemorrhagic stroke. This happens when a blood vessel ruptures, causing a bleed in the brain, permanently damaging the surrounding brain cells. Risk of stroke is increased by an irregular heart rhythm called atrial fibrillation, or having risk factors such as being older, having high cholesterol, high blood pressure, diabetes, smoking, or being overweight. Penny was at home when suddenly her face dropped on one side. She was unable to raise both of her arms, and her speech became slurred. Her husband immediately called 999. At the hospital, doctors gave Penny a clot-busting drug to break down the clot in her brain. Some people may have an emergency thrombectomy, a procedure to remove the clot completely, or another treatment to try and restore blood flow to the brain. The treatment given will depend on the type of stroke you've had. After her stroke, Penny's family noticed mood and personality changes, and she wasn't able to do as much as before. Depending on the area of the brain that is damaged and how quickly they receive treatment, people may also experience memory loss, tiredness, difficulty swallowing, muscle weakness on one side, or problems communicating. These can be permanent, but many improve over time. Following a period of rehabilitation in hospital, Penny made some lifestyle changes to continue her recovery and reduce her risk of suffering another stroke in the future. Whilst the effects of a stroke can be devastating, if you act fast and get the treatment you need immediately, this gives you the best chance of making a recovery and getting back to a normal life. More information on strokes can be found at bhf.org.uk/stroke. BHF, beat heartbreak from stroke. Beat heartbreak forever.
Don't call 999. As you saw, that was in the UK. Our 911 is their 999. All right, let's move into, and we're going to spend the rest of our time on depression and dementia because this is fairly new information. It is fascinating to me what has come out, the fact that depression can actually permanently change our brain. And like I said, there's some research that has come out just this year. They've been studying it for a long, long time because I have been hearing for many, many years as I have been checking people in to different places and getting histories on people with dementia. Well, you know, mom has had depression most of her life, or dad has just fought depression his whole life. But we weren't really putting the two together. And now look at these scans that we've got right here. Anxiety and depression actually change the chemicals in the brain. And they're changing the chemicals in the brain that are part of the hippocampus. And the hippocampus is the memory center of the brain. You can see there on the left, that is a healthy brain. And you can see the frontal cortex right up here. But a person with chronic depression, that's the one on the right. And you can see how it changes the metabolism and the blood flow. Somebody who has chronic depression. Now, where my concern comes in is that in the last 18 months, actually, we're about to go on to 2 years. We're coming up on 2 years. We've had a lot of chronic depression and anxiety going on. Just across the board as a nation, we've had it going on. Well, what if you were already somebody who had a lot of anxiety and depression? Another area of the brain that gets damaged by depression is that conflict resolution center of the brain. And that's in that prefrontal cortex. And that's part of planning and executive function. So the hypothesis is that's being drawn right now in research is that vascular lesions on the brain are appearing due to, here's the key, untreated depression. Untreated depression. What the research is finding, and we're going to look at it, is that those who are treating their depression are not ending up with vascular dementia down the road. So, depression and vascular dementia. Depression and anxiety are the most common mood disorders in the United States. But in the US, only about 1/3 of the people who have depression and anxiety are receiving any type of treatment. And as we're going to see later on, depression 100% of the time can be treated. Now, I didn't say 100% of the time it can be cured, but 100% of the time it can be treated. And 100% of the time we can receive relief. We can't necessarily cure it 100% of the time, but we can receive some relief. But only a third of the people are getting it treated. I'll be thinking about why that is. There's a stigma to it. So think about what depression actually is. It is a medical illness. But when somebody asks us if we're depressed, so many times we'll say no, because we think that depression goes hand in hand with sadness. But I'm going to show you all of the symptoms to depression, and you're going to see that sad is one of them, and you can be diagnosed with depression and not even be sad. Just like a person can be diagnosed with dementia and not have any memory loss. The memory loss can come later. A person can get a diagnosis of dementia and not have any memory loss yet. A person can be diagnosed with depression and not be sad. Depression leads to emotional and physical problems, and we see changes in our function at work, and we see changes in our function at home. And these are some brand new statistics that are out. And in Texas, we are very proud, and we like to be first, second, or third in most things. But these statistics are not things we want to be first, second, or third in, and we are. Now, I hate the term mental illness, but unfortunately, depression and anxiety fall under mental illness. As a therapist, I am big on, let's start calling it brain health, because if we called it brain health, more people would own it. We don't call it cardiac illness, we call it cardiac health when we talk about our heart. So these statistics use the word mental illness. So I'm sorry about that, but they do. Texas is number 2 in adult prevalence of any mental illness, number 2 out of all of the states. Texas is number 1 in adults with substance use disorders out of all the states. Texas is number 3 in adults with serious thoughts of suicide. Texas is number 15 in the youth with at least one major depressive episode in the last year. Now keep in mind, these came out in August. These are the 2020 numbers, so this is last year. Texas is number 3 in youth with substance use disorder in the past year, and Texas is number 3 in adults with a mental illness not receiving treatment. Now, again, we hear that word mental illness and go, that isn't me, that's somebody else, because I most definitely don't have any of that mental illness nonsense. What if we called it brain health? Maybe we'd be more likely to own it. Last year in 2020, an awful lot of people got online and did anxiety screens and depression screens because they were worried about themselves. There was a huge increase of people doing screenings on themselves. And 8 out of 10 people who took those screens scored moderate to severe. And 37% of the people who screened themselves said they had serious thoughts of suicide last year. And then we consider 31% of all suicides last year were healthcare workers. 31% of all completed suicides last year, not attempted, completed suicides last year. And 70% of those that did the screening said that loneliness and isolation contributed to their mental health concerns. This is an example of a depression questionnaire. This is just a sample one that you can find online. These are the type of questions that they ask, and you're supposed to read through these and see if this has affected you over the last 2 weeks. Now, as you read through this and you answer your own questions, You have to be real honest with it, because we all can look at that and go, well, I know what I'm supposed to say. I'm sleeping 8 hours every day. I'm exercising for at least an hour every day. I'm eating all my fruits and but no, you're not. That's a story. Don't tell a lie. You've got to be real honest on these. But this is just an example of what this one's called a patient health questionnaire. I just wanted to give you an example of what a real brief questionnaire might look like. And it typically will ask you over the last 2 weeks. Now, here are those symptoms of depression. Depression affects different people in different ways. Doesn't look the same on everybody. So take just a second and look at those. And I'll encourage you, when you get these slides, to print that off and to seriously look at it and get a highlighter or a pen. Now, what you want to think of is the last 2 weeks. The last 2 weeks. If you've had any of these in the last 2 weeks, or if you're sharing this with somebody, make a note, last 2 weeks. So it's the 8th. So the last week of October, first week of November, if you've had any of these feelings. Because for a diagnosis of depression, you have to have been having signs and symptoms for 2 weeks. Most of the time, by the time somebody goes to a doctor, they've been having it for much longer than 2 weeks. Much, much longer than 2 weeks. It's usually months before somebody will actually go to a doctor. So there's a whole lot more to depression than sadness. Depression is not a normal part of growing older. One of the highest groups of folks who commit suicide are white men over the age of 75. In people over the age of 65, depression can show up in a little bit different way. It can show up as memory difficulties. But if we treat the depression, the memory difficulties go away. So many times depression in people over 65 goes untreated because people will say things like, oh, that's just part of getting older. No, it isn't. When we start seeing personality changes, wanting to stay at home, becoming withdrawn, and especially if somebody starts having suicidal ideations, it's got to be taken seriously, because this can be treated. This isn't anything to be ashamed of. And anybody who's on this call, and with 22 people on this call, my guess is probably at least 15 at least have had significant depression, at least one episode. Here are the 5 most common types of depression. The bottom 2 are the 2 we've seen more of in the last 18 months, but these are the 5 most common types of depression. First, there's the chronic depressive disorder, and these are people who tend to stay depressed all the time. This is a depression that lasts for a minimum of 2 years. This is like a major depression that they stay depressed, but then it's like it will flare. So they'll have these major bouts, and then it'll be a little less severe, and then they'll have a major bout and it'll be a little less severe. But this is called a persistent depression. This is somebody who's kind of depressed all the time. Then there's a postpartum depression. You've probably heard of this one. This is a major depression after delivery of a baby. This is much different than regular baby blues. This is to the point that there's sadness, anxiety, to the point that a mother can't care for her child. And it is very, very serious and needs to be treated. So a lot of people have come out and spoke about this and made it something, again, to not be ashamed of. It's not anything that anybody has any control over. None of these are. Now, seasonal affective disorder, we are in the time of year because the time just changed where it is getting dark at 5 o'clock. Seasonal affective disorder is typically in the fall and winter, although it can be in the spring and the summer. We usually see it in the fall and the winter, where people will have social withdrawal, increased sleep, weight gain, and it'll return every year. Seasonal affective disorder, sometimes it's called SAD. A lot of people treat it like I do with light therapy. And I actually have a light here on my desk, and it's called a happy light. And it's light therapy. You can order these lights on Amazon. I encourage you to do some research on it. Light therapy for seasonal affective disorder. Find the one that's right for you. You can actually do this with people who have dementia. You can use light therapy. I have one just sitting here on my desk that I turn on a couple of times a day on really cloudy or overcast days, or if I'm going to be working and it's already dark outside. There's really something to it, to light therapy. Now, these last two are the ones that we've seen a lot more of in the last 18 months just because of what's been going on. Major depressive disorder or clinical depression. This is symptoms that last most of the day for 2 weeks, and they start to interfere. This is the main thing. These start to interfere with our work, our sleep, our study, our eating habits, and most people have at least one episode during a lifetime, or we may have multiple episodes. So that's a major depressive disorder. Now, some of us have had a major depressive disorder that started last March, and we're still in the middle of it, because we're still in a messy middle. This isn't new normal. I don't think any of us think this is the new normal. We're not going back to how things were, and we're sure not to the new normal. This is still messy middle, and we hadn't got it figured out yet. So we've got some people that have got this clinical depression right now. We got to call it that. And then we also have situational depression. And this is when we're sad or low because of a particular situation. And this is something that the majority of us have throughout our lifetime, because we lose a job, we get a divorce, somebody dies. This is where grief comes in waves. This is a little bit different from the major depressive disorder because our self-esteem is still okay. We'll be going along and we'll be okay. And then it'll be like a wave will come and kind of knock us down. And then we'll be okay. And then that wave will come. This is usually after that situation. Something has happened. Again, a divorce, a loss, something major in our life has happened. This that's happened to all of us, we all have this collective grief going on right now. It isn't over. It's still happening. So that's why we're seeing more of the clinical depression right now. So the risk factors for depression. Genetics. 40% of the time, if you had a parent who had depression, you're going to have depression, or you're going to have depressive episodes. 70% of the time, if you have an identical twin that has depression, then you're going to have depression. Now, that doesn't mean that 70% of the time identical twins have depression. It means that if an identical twin has depression, the other one will, 70% of the time. You probably could have guessed this one. Women have more depression than men due to hormonal factors. 1/3 of women will have a major depressive episode at one point in their life due to chemicals in the brain. And then this one's a shock. This is the one we've all been going through: environmental factors, psychological factors. And then depending on a person's personality, if somebody already has low self-esteem, gets overwhelmed easily, or if they just kind of have a pessimistic personality anyway, they're going to be more likely to develop depression. Somebody who has a physical illness is going to be more likely to develop depression. That is why that high suicide rate for white men over the age of 75, most of the time that's been after a diagnosis of themselves or a spouse. And then medications and medication interactions is also on there. Healthcare professionals, as I said, are at a very high risk for depression and suicide. And the reason for that. If I were to turn off my fake background right now, you'd see my wall behind me. And I've got all kinds of diplomas and certificates and things that say that I don't need any help. I'm the one that helps everybody else. And most healthcare professionals are that same way. Why would I ask for help when I'm the one that people come to for help? And especially in this last year, healthcare professionals didn't get any help. Now, the way that depression shows up in men and women is different as well. In women, we typically see depression show up as being sad. So we do tend to see depression as sadness, worthlessness, and guilt. Women will carry the guilt, sad, worthlessness, and guilt. But in men, it will show up as being tired, being irritable, and being angry. Tired, irritable, and angry. So how do we get diagnosed? Again, we need the symptoms to be there for at least 2 weeks, but usually by the time we do get to the doctor, it's been a lot longer than that. Please be honest when you go into your doctor. They're used to hearing this. We want to start with the primary care physician. They're going to do a diagnostic exam. They're going to do an interview. You've got to tell them the truth. Start journaling and write all this down. What are you feeling? When are you feeling it? Is the same time every day? Is it after a certain event? They're going to do a physical exam. They're going to do lab tests because we want to rule out all this other health conditions. You may be having thyroid issues. Thyroid issues can mimic and cause some depression issues. Vitamin deficiencies can mimic depression. Let's get our vitamins under control. They're also going to explore your medical and your family history, as well as cultural and environmental factors that are going on. Right now, the doctors know a lot about the environmental factors that are going on. You can also see a psychiatrist. Psychiatrists will do the same thing as the primary care physician, but they specialize in mental health. Typically, what they do is they will write prescriptions. They may start you on an antidepressant and then recommend a therapist. There are psychiatrists who do therapy themselves, but many psychiatrists will handle the medications and then send you out to somebody like me, a licensed professional counselor, or a licensed clinical social worker, or a licensed master social worker, but they'll send you out to someone else. And then licensed professional counselors, LCSWs, LMSWs, and there are others out there, can do assessments. And we can do assessments for depression with depression scales. And then there are psychologists, which can provide in-depth psychological testing if that's something that's needed. And many times it's not anything that's needed, but I just wanted to give you a breakdown of things that can be done. Now, this is what's huge. And if you take nothing else away from this about depression, please see this one. That's why I put it in bold, in red, and underlined. All depression can be treated, and 80 to 90% of it can be cured. And another 20% of it, you can see a reduction in symptoms, but you got to treat it. And the earlier the treatment begins, the more effective it will be. Just like anything else, no two people are going to present the same way. And with antidepressants, just like with high blood pressure medications, no two people can start with the same dose at the same time and react the same way. Our bodies are different, and it may take some trial and error to find a treatment that works. And the same thing isn't for everybody. Antidepressants are not habit forming. Antidepressants are not uppers. That's a myth. You don't get high off an antidepressant. Antidepressants and anti-anxieties are completely different medications. An antidepressant actually helps the brain improve the way the chemicals are used, and it helps control the mood. Now, we looked at those scans that showed what depression is doing to the chemicals in the brain that's damaging them to the point that dementia is developing. And an antidepressant can stop that. They can take up to 2 to 4 weeks to work, and sometimes it can take 2 to 3 months for full effect. And normally by the time we go to the doctor, we're to the point that we want something to work right now. And it just doesn't work right now. But if you keep taking them, this is where you start getting the symptom relief within those 2 weeks. You might not have the complete mood lift, but you might start getting help with the sleep, the appetite, the concentration. Other things that you can do is counseling. Some people call it talk therapy or psychotherapy. These are the 4 most common that are out there. Cognitive behavior therapy has been around a long time. This is what the majority of counselors do. You may have heard it called CBT. And this focuses on problem solving. It teaches you how to reframe. It talks about staying in the present. This is a lot of what my support groups do. We reframe. We don't focus on what our loved ones can't do. We focus on what they have left and quality of life and reframe. There's also interpersonal therapy, the problem-solving therapy, and you may have heard a lot lately. I added this one on here about EMDR therapy that's very, very popular right now. It's been around for a long time. It's just been in the news recently because there's a lot in the news about trauma. EMDR therapy is called eye movement desensitization and reprocessing therapy. It doesn't all have to do with eye movement. All it is that it's a bilateral stimulation that's used during therapy. A lot of people have you hold a couple of things in your hand that kind of buzz back and forth as you're doing therapy. And this is for trauma treatment. This is not for your regular day-to-day. This is for people who are going back and healing from symptoms of trauma. Other things that you can do for depression. The actual number one thing that you can do for depression is exercise. And usually when you're depressed, that's the last thing you want to do is exercise. But one of the best things that you can do is exercise, is because you get an oxygenated blood to your brain, which helps you produce serotonin and dopamine, which are those feel-good chemicals, which is what we need. So that's some of the best things we can do. And I always encourage people to start with 5 minutes. Can you just start with 5 minutes? Setting those realistic goals, getting that education. There's several on there. I want to make sure I get through these and leave a few minutes for questions. So I'm going to keep going. Again, you're going to get these slides. Never ignore comments about suicide from anybody. We see that enough in the media. You know, who would have looked at Robin Williams and ever thought that that man was suicidal? Who would have looked at Robin Williams and thought he was depressed? I've got a whole program I do on depression, and I've got all these celebrities I pop up there that have come out and they talk about depression. Bruce Springsteen talks about depression, Lady Gaga, Michael Strahan, Katy Perry, you know, all of these different celebrities who now have owned and talk about their depression. I'm so glad they're starting to do that so that they're not making it something to be ashamed of. Here's some resources. This is a chart that shows how depression is directly related to dementia. Again, how it breaks down into the vascular disease, how, the inflammation in the brain, the plaques in the brain. So if that's something you're interested in, I put that graph on there as well. Here's our information, how you can get in contact with me. There's our phone number and there's our my email. So let me stop sharing, see if anybody has any questions or comments. And like I said, you'll get these either later today or tomorrow. You can either unmute or you can type in the chat.
Hi, this is Stephanie.
Hi.
I just wanted to say this is probably the topic that is least discussed and right now in the world so needed.
Yep.
I have a 21-year-old and 18-year-old, and they're suffering. And when you work in senior living, we all have PTSD, it seems like, from COVID. Thank you so much for doing this.
Yep. I just did a program on depression versus dementia at the Texas Assisted Living Association 2 weeks ago. And I have received phone calls, emails. I had people standing in line to talk to me afterwards going, thank you for making it okay to not be okay.
And that's what I've been trying.
Yeah.
My kids have had people, friends. Each one of them have had a close friend commit suicide.
Yeah.
And they've had to grow up really quickly.
Yep.
And it's a struggle for a lot of people to stay in senior living because it's so tough right now.
Mm-hmm.
I'm a sales director, and it's different.
It is. It is. And the other thing that came up was, we've been trying so hard to take care of our residents, take care of our families, take care of our staff, that making sure, or we were taking care of our leadership teams, because that's where a lot of the, whenever you start looking at the statistics with the suicide were taking place. So, making sure we're shifting focus, and we got to start taking care of ourselves.
That percentage blew me away.
Yeah, huge.
It really did. And I'm sending this. When you send it to us, I'm going to send it to my leadership, and maybe even suggest that they have you do this one of these for our team.
Sure, absolutely.
Because it's really great. Thank you.
Yep, thank you.
Holly, it's Debbie.
Hi, Debbie.
I have a question on, so it said on your slide that antidepressants are non-habit forming,
Right.
but then at the bottom it says, I think it said, don't discontinue or go off of these without a doctor's help.
Right.
So how, I guess I'm confused by that.
It's not that it's habit forming, but because it is affecting the chemicals in the brain, if you ever try to come off of something, all of a sudden it can cause some really, it can make you have really severe headaches. You can just have some side effects that are not pleasant. So it's that type of a thing.
Okay. Yeah. Good.
Because it is affecting the brain chemicals. It's not that you get to needing it, but you can have side effects from it. So just like you titrate up, you titrate down, if that makes sense. Yeah.
It does. Thank you.
They start you on low dose and go up, and so then you come down off of it. I have done that with antidepressants before. I've gone on and off of them my whole life, and I have just decided before, well, I'll just stop doing this, and had some of the worst headaches of my life. I learned the hard way because I didn't need any help. I know what I'm doing. I'm one of those people with diplomas on the wall. So I just stopped taking them. Boy, I learned my lesson. There's a reason you're supposed to titrate off of them, because it's your brain chemicals. So yeah, that's what it is. It's not that it's habit forming. It's just that you're going to have side effects from it.
Yeah, but it's great to know that it's not habit forming.
Yep, it's not.
Yeah. Okay, good.
Anti-anxieties can be. There's a big difference in anti-anxiety and antidepressant. All right, thanks everybody. If you have any other questions, you can email me. You will, like I said, you'll get these slides. You'll also get a copy of the recording. I appreciate y'all. Have a good rest of your day.
Thank you.
Thanks.
Thank you.